Good afternoon. So welcome. Happy Monday afternoon. Welcome to the Center for Innovation in Mental Health second annual Mental Health Methods series. My name is Sean Haley. I'm an assistant professor here at the CUNY Graduate School of Public Health and Health Policy. And it is a pleasure to be able to host the first presentation of our series this year. I'd like to recognize a few people. Dr. Jennifer Wisdom, the director of the Center of Innovation in Mental Health. Some staff. Yes.
We just stepped out. Evelyn's here.
Evelyn's here. Yeah, looking at. I don't have my distance glasses on, so if I'm hesitating a little bit, I can't. I refuse to get the bifocals in because I clearly am not that old. So Evelyn, and then we have guests from the city as well. Is that right? So welcome everybody. It's great to have you here. I'm also really excited to be able to introduce not only a colleague but a friend. Maria and I have known each other, I'm not going to say out loud, we're just going to keep going. Yeah, thanks. For a couple of years. And I asked Dr. Kearns to join us to launch the first in our series because Dr. Kearns is really a master at figuring out how to make divergent expectations and rules comprehensible. She is also really skilled at bringing out best and sometimes really contrivance while developing robust programs to ensure the best possible outcomes for patients with very serious mental illness. My hope is that she will share some of those strategies with us. Very good. Let me give you a little bit of background. Dr. Kearns is the regional director of the Philadelphia Behavioral Health Services at Horizon House. Horizon House is a large behavioral health developmental disability services organization operating mostly in southeastern Pennsylvania and Delaware State. Dr. Kearns earned her doctorate in social policy from the Hello School at Brandeis University, a very fine program, if I do say so myself. Yeah, of course. Before getting her doctorate, she earned her MSW from Boston University School of Social Work and a BSW at Salem State University. I'm not going to say how many years of experience Dr. Kearns has in both clinical and managerial because I'm afraid I might get in trouble for saying that out loud. But she is a true expert in both management and direct care. And Maria, I'm so very happy to welcome you.
So this sort of feels like church for everybody. So I'll try to use this mic and project back there. And so thank you, Sean. Thank you, Dr. Wisdom, for having me. This is not what I usually do. I'm usually the person who's at an agency who looks at all kinds of requirements coming in, and then I get on the phone and I start pulling people together and we start having meetings and having conversations. So if I lose my track a little on the podium, be kind, because I'm not usually a podium speaker. So our goals for today is to make this thing work.
Right out.
That's a right arrow.
How about a down arrow? How about, so if you move the little wheelie thing?
Okay, we'll move the wheelie thing. So today I'm hoping to help people to understand some of the relationships between contract measures and client outcome variables. Also to differentiate between contract outcomes and individual client outcomes when we talk about program evaluation. And finally, to identify some operational strategies to build efficiencies between contract and client expectations. Many times we look at things and They seem like a logical, simple situation. Just collect data on X, Y, and Z. And that might be simple, and it might require gathering information from multiple sources. So trying to meet all of those expectations requires really learning how to walk something through and map it out. And then saying, I don't know if we can exactly get this way. How do we need to change it? You know, when I did my dissertation, I decided to be kind to myself and used an existing data set. That was great. It didn't exactly have what I wanted in it, and I couldn't go changing and ask the question because it was a longitudinal study and it was a large data set. So I had to use what I could and to make adjustments. And in many ways, it's that same kind of situation that we have to go from the policy aspects, contract aspects, research aspects, to the actual program and the clinicians entering information and the participants that we serve giving us information. And how do we navigate that whole thing? Wrong way. So if you think about layers, and we'll talk about layers a bit today. Federal government, they have performance expectations and obligations of people who participate in Medicaid, Medicare, and block grant funding. The state has expectations of people that they provide funding to, either through contracts or through Medicaid, not Medicare in the states. And then you have places like Pennsylvania. Pennsylvania does everything by county. So in addition to the federal and the state, you now have county expectations. I was saying before we started to Dr. Wisdom that, you know, I've worked for our organization. It's about an $84 million organization, and I've worked in various regions. And every region had a different funder, different set of expectations, even though it's the state of Pennsylvania. So each of those is allowed, each county is allowed to customize things to meet the needs of the residents in that county. That's a great thing. It's a little bit of a nightmare to collect data. Mental health service programs are required to submit data, and we get given prescribed formulas. This is what you must submit. So if you'd like to get paid or you'd like to use this money, you have to submit the data in this way, in this time frame, format, etc. And then the belief is that by submitting all that data, it will demonstrate program achievement across specified outcomes. We'll talk a little bit later about why that isn't exactly the case. And there's no thought about the organizational resources that are required to produce the required data, and it's considerable. So today I'm going to use one of my programs as an example, because I do much better with real life things than theory. So we operate a first episode psychosis program. It's the PEACE program of Horizon House, and it's psychosis education, assessment, care, and empowerment. It's a first episode psychosis program for individuals aged 15 to 30 who are experiencing their first episode of psychosis with no more than 12 months of symptoms prior to entering the program. They stay with us for 2 years. We utilize the coordinated specialty care model, which has been tested and researched under the RAISE studies through SAMHSA. And we were the first episode psychosis program in Pennsylvania using that model. University of Penn started a program about the same time as us, but not using that particular model. I will forever be going the wrong way. So again, we talked about layers of expectation. So we have 10% of the mental health block grant was set aside for use for first episode psychosis programs. Federal block grants have specific expectations in terms of data you collect and reporting requirements. They also set up for there to be a study done on programs who receive this funding. So there is a study going on right now with 38 sites across the United States. The 10% study came after the Pennsylvania money's going out. So we also have a Pennsylvania program evaluation of 8 sites that received money in the state of Pennsylvania. We then said we need to get paid in a certain kind of way. Initially, they were trying to figure out how to fit us into a box. And so the box they decided worked best was outpatient mental health. The coordinated specialty care model is a team approach that has varying levels of intensity of services and in varying locations. There's also services provided that are not necessarily Medicaid reimbursable. In an outpatient model, individual therapy for adults in an office is paid for. Group therapy for adults in an office is paid for. The doctor can actually travel. It's a doctor, they can get paid mobile or in office. And for children under 18, we were able to be paid for seeing them in the community and mobile. That left about 60% of the services we provided as unfunded. So that really wasn't going to work. So in some ways, the 10% set aside and some of the expectations of that did help us. And so we submitted an alternate payment arrangement request for what's called a supplemental service. So Medicaid has in-plan services. States are allowed to offer additional services that are outside of straight Medicaid's in-plan services. They're called supplemental. And so that's what we requested, and we were approved for that. I'll tell you more as we go on.
Quick question.
Yeah.
Can you tell us what are the other kinds of services outside of group and individual therapy that you would offer in this RAISE model? Just so everyone.
Yeah, in the RAISE model, the individuals receive typically it's called medication management, except in the RAISE model, it's more shared decision making with the psychiatrist around the need and the use of medication. So technically, if I bill medication management, and I report medication management, but when you actually see what happens with the individual, it's shared decision making about, does this medication work for me? The RAISE model says to use the least amount of medication to allow the person to function in the way that they need to function in their lives and in the community. So if I give you enough medication that your symptoms go away, but you're unable to get up and go to school, then that's too much medication. So shared decision making, we do some decisional programs with people to say what makes sense in your life and how do we step back and achieve that. So that's the medication piece. Individual therapy can occur as little as once a week to as much as 5 times a week, depending upon somebody's need and where they're at. We offer a variety of group therapies and psychoeducational groups. So we also teach people, we have mindfulness groups, yoga groups, art groups, music groups. It's about utilizing everything and every different way to engage an individual. We also bring the service to them. So if they're having difficulty in school, we go to school. We assist them in getting special education services that they may not realize that they needed. We assist them in getting a job, and we do good job coaching. So if somebody wants to work, but has had a difficult time either getting a job or keeping a job, we identify sort of what are the barriers for them, and we work with them to overcome those barriers. So it's a really comprehensive support service. The difference between that and an ACT model of care, served community treatment, which is also a multidisciplinary team that offers many of the same components, is in the ACT model, in order to get that service, you've had to have failed at all lower levels of care. In a coordinated specialty care post-episode psychosis model, this is the entry to care. This is where we want you to end. The goal is to decrease the duration of untreated psychosis. Because we've seen in years and years of studies and just practical experience in our offices that the longer someone has untreated psychosis, the more difficulty they have in their lives. So we want to decrease that duration of untreated psychosis, get the person grounded back in school, work, and meaningful activity, and try to put the rest of my organization out of business, basically what I say. I want people in early enough that I'm not providing services to people with chronic mental illness who are not able to participate in many of the activities that they had wanted to in their life. You talk to people in their 50s, and they're saying, I wanted to do this in my life. I wanted to do that. But there was not supports or services for them. So coordinated specialty care is a great model. It's very promising in terms of changing people's lives. It's a little counterintuitive to funders because it's actually more expensive than traditional care. So it's way more expensive than sending someone to see the psychiatrist once a month or once every 3 months and seeing a therapist once a week. That other model is not, outpatient model is not as effective. So this is effective, it's time limited usually, and really helps launch people into a better trajectory of recovery. Did that answer that? Okay.
Thank you very much.
So since it's such a great model and it does great things, the managed care organization, Pennsylvania does carve-outs, so we have carve-outs for behavioral health, starts out by saying, well, we're giving you this APA, and Pennsylvania is insisting on 20% of contracts being value-based payment. So they'd like us to come up with all of the indicators that we would then be paid for the performance on. So the indicators that they've now suggested is employment, education, decreased hospitalization. Are all of these things totally within our control? Yes, no. So I'm not sure that they measure as much the success of our program as the success of our program in the context of the person's life and in the society. Pennsylvania is a very diverse state in terms of socioeconomic status, but Philadelphia is not. Philadelphia has the greatest percentage of what they call deep poverty. Individuals who live at or below the poverty level. If you drive through Philadelphia, you will see street after street of abandoned buildings and crack houses. Every day, there's a murder or 2 or 3. Every day, there's opiate overdoses. So it's really a challenging community to provide these services in. So when we talk about education, with a failing school system, we talk about employment in an area that has very few jobs. Am I being paid for what I'm providing? or am I not being paid for what the community is not providing? So when we talk about value-based payment for performance, it's how do you tie the correct thing to the performance? What is the right metric? And that's not a simple answer, because what's the right metric in Philadelphia may be a very different right metric in an affluent community. So thinking about the context of these is really important. So then you also add on agency expectations. My CEO would like me to not lose money. In a nonprofit that sometimes hasn't gotten a rate increase, most of our programs have not received a rate increase in 10 years. The City of Philadelphia gave everybody a pay raise. So the minimum pay in Philadelphia was raised from $7.50 or $7.25, which is the federal level, to $10 as the minimum. Our peer specialists are required to be paid $13 an hour. So there's a lot of mandates in there, but my rate is still the same as it was 10 years ago. So it's been a very interesting process to manage these contracts and these programs in ways that allow you to provide the services to the individuals in the way they need to be provided, but also then figuring out how do I balance this budget. Fortunately, most of my program directors don't have to worry about that. I do. So we have the agency expectations. If we have CARF accreditation, some of our programs are CARF accredited, which is Commission on Accreditation of Rehab Facilities. Hospitals have JACO, Joint Commission on. So you have expectations then in your organization to meet certain standard accreditation. The board of directors gives you expectations. They would like me to not lose any money in my outpatient department. If anybody's ever worked in an outpatient clinic or done any management, I'm not sure how you don't lose money unless you have all fee-for-service clinicians who you only pay for the service that they provide and only pay when the check comes in. There's actually providers who do that. They're now clamping down on providers doing that, so everybody else will join me in losing money because we actually hire our staff, give them benefits and a living wage, and we pay them for the work that they do. So, but that means I have agency expectations. And then the program itself has expectations. So that the program expectations can be around their credentialing, their licensing. It can be just what the staff in that program hope to achieve. Everybody forgets that sometimes there's things they want to achieve as well. And so the program starts to set their own expectations in addition to meeting all of these other layers of expectations. So if I scared you all away from ever working in an agency. Okay, let's see if I'm going to go. All right, so the federal block grant. I'm just going to quickly go through a bunch of these things just in case you don't have any clue about any of these. So the federal block grant is a grant that is given by the feds to the states so that they can provide services primarily for people with adults with serious mental illness and children with serious emotional disturbances. It is the federal way of saying to states, you know, you can customize things. It's the one area that we're not going to tell you exactly what you have to do, but you still have to plan it and get us to approve it. But it allows more customization for a state. Alaska is not the same as Pennsylvania. It's not the same as New York. So that gives that flexibility that some states really need. Of course, nothing comes for free. So they expect recipients to do certain things. So you have to have that plan that they say, oh yeah, that's okay. You have to make sure that it targets the right people. So you can't say, oh yeah, we're going to use it for adults with serious mental illness and children with serious emotional disturbances, and then offer services to child care for women who are low income. There's ties that you must do and that they have to approve. The states then also have to submit an annual report on their plans. Did they achieve the things that they said they were going to do? And there's some core services that the block grant does mandate. So those are screening, outpatient treatment, emergency mental health services, and day treatment programs. The day treatment programs are changing over time. Used to be partial hospitalization programs. Most of them have converted to psychosocial rehab programs, which is a really good thing. But there is some kind of day programming that they expect from the block grant. You have to follow their rules. And they can come in at any time and say, okay, we want to look at your stuff. We want to look at the state's reports, the state's data. We want to actually go see a provider or two and see what they're doing. Because they want to make sure that their money is going to where they intended the money to go and where a state said the money was going to go. They check to see how you're tracking where the money went. Did it get to the right recipients? How do you know? So the state data systems, how do they know what they're doing? They expect that there is core data collected on the individuals served and that they have some kind of performance management. They don't dictate the performance management, but they expect some kind of performance management. They also expect that you can document and demonstrate collaboration with consumers. So different places do it different ways. And Pennsylvania, they actually have committees in each county that meet on a monthly basis. And the county mental health office meets with this group of and providers as well go to it. And they talk about and ensure that the consumer's voice is heard in the plan. I did that one. So the 10% set aside. So I started by talking about the example was going to be for our first episode of psychosis, 10% set aside. In 2015, there was a 5% set aside. And then in 2016, Congress directed that there would be a 10% set aside. And it's very specific. It must be to provide treatment for those with early serious mental illness. It's not for anybody else. From the 10%.
Muted.
Welcome. This service is provided by freeconferencecall.com.
There is one other participant in the conference. Please announce yourself.
They are assessing deviation from the scientific model, and if so, how? Have they developed standard metrics to assess how many points away you are from their real fact?
Yeah, there's actually a fidelity measure and standard for the RAISE model, and so that part of it is actually easy. You have this, you don't have this. The implementation part, how do people implement it, in what ways, divergent ways?
By whom, with what?
That's going to be a little bit challenging because some programs are up and running, some programs are brand new, and they're developing. So that one's going to be more qualitative information versus any kind of true data and analysis, because people are too far all over the place. The other part is, when you look at it, the program that I run receives $155,000 a year in first episode psychosis money. There's another program in Pennsylvania that gets $390,000 a year. There's a program in Utah that I was at the Washington meeting with that gets about $900,000. So how states also contracted and they gave pools of money is different across the board. So that, again, starts to impact how it's implemented and how it's going. We're primarily funded by the managed care organization in terms of billing for the services versus getting a ton of money out of the first episode psychosis dollars.
Yep. So I understood you say earlier that you were in your RAISE model being able to get reimbursed for IEP services and special education services as a preventative technique. Did I understand that correctly?
One of the core services within the coordinated specialty care is that you provide support and advocacy to get people what they need in terms of being successful in education. So we're not technically paid for developing an IEP, but we are paid for coordinating that development of the IEP with the school system, going in, helping mom request it, helping the child request it, participating in providing information to the school, assisting in getting the young person to whatever testing and assessment needs to happen, and also providing support and training and education to whatever teachers are working with that individual around that specific youth's needs.
So are you tracking the effectiveness, because that's an important intervention in all early psychosis models in terms of preventing both alcoholism, substance abuse, as well as repetitive problems in terms of repeated events. You've been tracking the effectiveness, because that's something that's, I don't think, done very often, where they get involved in the school system.
Yeah, it's not even easy to get involved
Right.
in school systems.
Right.
So that's a tremendous challenge. We do keep track of pre-education success, so how they were doing in terms of education prior to coming into the program, and post-admission education success, which is not exactly getting directly at the IEP and how that's worked. And what we have found is once young people are admitted to our program, their involvement and attendance at school. Lots of kids are enrolled in school. That doesn't mean a whole lot. Their attendance at school increases significantly. And so that's where we can sort of see, okay, we're not measuring exactly, are they following the IEP perfectly, but we can see that whatever supports we've given, that young person is now showing great attendance in school. And it's been interesting to see how many things have improved that we didn't expect. Substance use drops off 65% after admission with no substance abuse treatment. So by virtue of someone helping them to deal with their symptoms, They're not using whatever substance that they can consume to make that symptom go away. Where we don't see the progress is with K2. And then the question is, what comes first, the chicken or the egg? So is it K2 causing psychotic symptoms, or is it psychosis being impacted by K2? Usually once we have somebody with us for a while, and if we can help them to stay abstinent, we can start to see a little bit more about what it is. But that one's a really difficult one on any of these. Did that answer your question?
Yes, thank you.
Right, I don't want to get stuck here. That 65% reduction, it's sort of beautiful.
Yeah, it is.
That's really outstanding.
Mm-hmm. Yep. That, you know, and even hospitalizations. I did say, we'll talk about the value-based payment. One of the suggestions was decrease in hospitalization from pre-enrollment to the program and post. And I said, so what happens when we do our job right and we intervene even earlier before the hospitalization? Because a hospitalization post might actually be a positive thing. But if my value-based payment is that it has to be a decrease, the payment structure is looking at that as a negative. They did actually say, yeah, that does sound a little wrong, but it still will probably be one of the variables. But typically for parents, they don't know what to do. So their child is saying that they're seeing things, their child is really not looking okay, is failing out of school, is using all kinds of substances, is talking to hallucinations, and parent says, what do I do? Typically, they wait until there's a crisis, and then they bring the child to the hospital. If you have insurance, you are admitted. Unless you have insurance that really micromanages eligibility, but if you've never presented and you're hearing voices, they will pay for an admission. So that child typically starts care in an inpatient unit. Has anybody ever been on an inpatient psychiatric unit, not as a patient, but just been on one? So about a half a dozen of you. One of the things that we think is you go to the hospital and they make you better. And then you leave when you're better. In an inpatient psychiatric unit, it is very hard for someone with a psychotic disorder to get better. Because one of the things that forces symptoms to emerge is stress. And an inpatient psychiatric unit can be extremely stressful. People are there for all kinds of reasons. So you have people who are loud and making a lot of noise. You have people who are aggressive. There's just behavior that, for some people, especially a young person who's 15 years old, can be extremely frightening. So in fact, I consider having an inpatient psychiatric commitment as being a trauma event in someone's life, because when you actually talk to them when they're better, they talk about how traumatizing that was. So hospitals are not good. So we want to actually get them before. We want to have that relationship with school departments so that it occurs before. But then I won't get my payment for value-based. You know? And the study through CIMH is going to be a 3-year study. So there's a couple of elements to it. They do fidelity interviews. They do them by phone. They do in-person visits. They come out to the sites. When they come to the site, they meet with the director, they meet with some staff, they meet with some recipients of the services, their families. They want to actually see not just I'm sending them information saying, yes, we're following the model. They want to see evidence that the model is followed. They want to look at records and see that we're providing the scope of services that are part of the model. This is when you start to talk about burden to an organization, because there's this lovely little sentence in here, de-identified. Yes, de-identified. Do you know that you're required in a clinical record to put someone's name and an identifying piece of information, such as their date of birth or something, on every piece of paper? Every piece of paper. So to de-identify means I have to get it off of every single piece of paper. If you have an electronic health record, you cannot remove it within the electronic health record. So you either have to spend crazy money to get the software company to figure out how to de-identify for an audit, or you print everything and you become best friends with the Sharpie. It's not fun. So 10 charts de-identified. When you're talking about, I might have 4 or 5 different people working with somebody. They could have 10 contacts a week. Every contact is a note. That's a lot of de-identifying. We're still trying to debate who's getting stuck with that job. I have told people who want to produce the lowest amount of services, they're going to get stuck. So it's trying to incentivize providing a lot of care. But that's, again, these burdens on the provider that we don't think about. It makes perfect sense. They have to have the identified data. They cannot be, we'll have umpteen HIPAA problems, and if we have identifying information, but it's not as simple as, oh, just click something in the computer and it takes it out. It doesn't work that way. So the staff have to participate in the interviews. They have to collect all the data, because someone has to get it. So who gets it? It's the clinician who's working with the person. And then again, we de-identify it, and we do these measures multiple times. So this is just to give you a quick overview of what some of the data is. So this is their minimum data set outcome for client level data. So you have all of the demographics. So this gives you the broad. Of course, we all know that there's a million little checkoff boxes underneath many of these. The enrollment status, is it referral only, waitlisted, admitted, an assessment process, like what's the status of the person? What's their insurance, the date of onset of psychosis, and they would like you to go back into literally trying to give them a date. The diagnoses, all of them, but you must have the diagnosis that includes psychosis. They would like to know about the use of antipsychotics, as well as their adherence to the use of antipsychotics. Employment and education status, is it full-time, is it part-time? That is doing weird things. And as well as, are they housed, are they not housed, are they homeless? We continue, that was the first page, was the easy ones. Now we get into tobacco, alcohol, and other drug use. What is it, how often, how frequent, the whole 9 yards. And is there a diagnosis? And what is that diagnosis? Psychiatric inpatient hospitalizations in past 6 months or during the time period of data collection. Number of admissions, number of days in the hospital. You would think that that was easy information to get. It's actually not. It gets complicated. If they go to, and we're still waiting actually for the answer from the feds on how they want to handle this. In Pennsylvania and Philadelphia, you go to a crisis center, which is basically an emergency department for mental health issues. So the question is, do you count that as an emergency department visit? if it resulted in a hospitalization, or do you count that only as a hospitalization? And you only count the emergency department visit if it didn't result in a hospitalization. You would think this was simple. Nope. And then it goes through a whole other legal issues, arrests, are they on probation, are they on parole in the past 6 months? And again, we do 6 months, 12 months, 18 months. It's all good information, but it's just has to get collected somehow. Then they'd like us to use a whole bunch of standardized tools. Now, the fortunate thing is the Pennsylvania study, the principal investigator on the study is actually, we contract with the University of Penn for the psychiatrist who is in charge of our program. So she likes standardized instruments. She put a lot of them in. So in reality, most of the federal ones we actually do. They managed to find one that we didn't do. But overall, we're doing them. But you can see, these are all instruments. Some of them are self-administered, some the clinician has to do. Suicide attempts in the past 6 months. What do you count as a suicide attempt? How do you know that? Is the person just cutting? Or was it a suicide attempt? Sometimes you know, sometimes you don't. So now we're at the feds, right? Now we move to the state of Pennsylvania. State of Pennsylvania gave us all this money and they said the 8 sites must participate, mandatory. So receive the funding, you had to participate in the evaluation. I personally would have said for $155,000, yeah, no. I couldn't even keep the $155,000. But since we were the first program and we had the PI, I really couldn't say no. The next burden is all of the data for these particular sites have to be entered into REDCap. They're like, oh, it's free, you don't have to worry about it, it doesn't cost the programs. I have an electronic health record. My electronic health record doesn't talk to REDCap, and REDCap does not talk to my electronic health record. So I have clinicians who are completing an admission form in REDCap and completing an admission form. Both of these are actually comprehensive biopsychosocials in an electronic health record. And it's not like I can print the REDCap one and scan it into my electronic health record, because one doesn't ask all the questions we have to ask. But the other is, if you understand the electronic health record, certain things then populate other forms and documents. So if I don't actually enter it into the electronic health record, it can't auto-populate other things. They thought this was going to be like so simple. Oh, just add it into REDCap. It doesn't cost you anything. Fortunately,
How much time is it costing for one patient intake record in REDCap?
It's adding about another 3 hours for all the forms that need to get added into REDCap per patient.
Times whatever that person's salary is, right?
3 times. So then you have salary. Unfortunately, we're not case rated, because if I was being paid solely by the units of service, this would kill me.
That's a lot of money.
Yeah.
I'm already jumping to the end of, so how do you fix this? But I will wait patiently.
Okay.
Your
So-
recommendation, love to hear your recommendation. Because I'm thinking of every program that we've ever done where we ask sites, oh, could you just collect this little bit and put it in an Excel spreadsheet, and could you do this, please? And it's not that much. But now I'm seeing that, I mean, I knew there was more, but I didn't realize it was this huge. And for agencies that don't have someone like you and don't have kind of a large infrastructure to be able to move money around a little more easily, this has got to be killing them.
Right, and for people who don't even who don't necessarily understand the overlaps and how to maneuver them, they typically go, okay, and they just do it. because they think that they have to do it, and they go, okay, they don't, because they can't figure out something else to say, can we do it this way? Can we do it that way? Yeah, it's challenging. So the other parts of the Pennsylvania program evaluation is program fidelity to the model. Fortunately, that mirrors the feds. Thank you. The Pennsylvania one, the performance measures are primarily client outcomes versus the NIMH study has a little bit broader than client outcomes. It has more, it has program outcomes as well. So, I'm not going in the right direction. Admission form, standardized tool, discharge form, follow-up forms, self-report scales, clinical assessments, keep going. And then these are some of the things that are on the referral tracking. So it's the source of referrals, because the goal is to identify and target outreach and psychoeducation. So we see that most of our referrals are coming from inpatient units. I don't actually want to target inpatient units. I want to target school departments. I want to target faith-based organizations. I want to go see the priest, the rabbi, whoever, and talk to them about what happens when one of your families comes to you and says this is going on with their child. We want to get that earlier. So by tracking the referrals, we can see where we're getting people from and are we being successful in targeting early intervention. Tracking the pathway to care can identify the barriers, we want to create a system for improving care through reducing the duration of untreated psychosis. So finding those pathways of how people get to us, which ones are more successful in referring that person and then getting them into the service, is an important piece of information. Admission does all of those same kinds of things on the other, all the demographics, substance abuse, work, education. The admission form, as I said, it's similar to our biopsychosocial. It's just in REDCap. Standardized tool, discharge. Why would they discharge? Where will they discharge to? What's the clinical opinion about their recovery? We are a 2-year maximum program. So in the federal study, not everybody is a 2-year maximum program. Ours follows the most rigid of the guidelines. So that's 2 years. We also only take people with psychosis in the last 12 months. Anything beyond that is really a long duration of untreated psychosis, and the goal is to change the duration. So again, it'll discharge data inform service utilization, including average length in the program, and seeing in fact, if someone is 2 years and we need to discharge them because they hit the 2-year point, what's their outcome at the end of 2 years? Should it be a hard 2-year? Should it be extended? Does it need to be as long as 2 years? And that's the goal of some of this. Follow-up forms. Anybody ever try to do follow-up? Yeah. So many of our clients don't have cell phones. You could get what we call the Obama phone. So Medicaid recipients can get a cell phone. You can only get one per address. And if you lose it, it's real hard to get another one. So we have lots of people who have no way of reaching us and us reaching them. So we want, in the follow-up, updates on diagnosis, education, employment. So sometimes we're able to do that. We usually ask people for multiple alternate phone numbers. And sometimes grandma or auntie still has their phone, and we can try to outreach. There's lots of self-report skills. I'm 15 years old. I'm psychotic. I don't don't want to talk to you. I don't want to talk to any professional. And we would like you to fill out all these forms. The reading level for most of these forms at lowest is 4th grade. Typically, they're targeted more about 7th grade. We're finding that we have people reading at 2nd grade. This is Philadelphia. So these forms can then, the responses to these forms can be skewed because people may not understand the questions. So the only way to take care of that is to actually have them do the self-report forms with a clinician available to translate it into ordinary English, which again adds more time. And here's some more. You didn't know how many forms there could possibly be about psychosis. There's a lot. Again, we're doing certain things at 6 months and baseline. There's some of these forms, again, done by clinicians, some self-report, some by the psychiatrists themselves. I always laugh when the psychiatrist that we have is the PI who says, this form just takes too long. And I went, yep, and you picked it. And she's like, I know. But when you pick things, you don't always think about how long they take. And then you're implementing it and you go, oh, that was not what I had thought. Literally, when I was given all the tools, I was given how long it took. Things were 5 minutes and 10 minutes. And take every number they give you and at least double it, typically triple it. Those numbers are never right. Unless they're doing it in a college classroom and having you guys tell them how fast it can be done, and clearly you are not the person I'm serving in my program. Measuring fidelity, they're going to use the same thing as the feds, which is nice. But then you get in, geez, my organization and my program has things. Yep.
I'm just mindful of time, so I'm wondering if we might move to the, so how do you make all of this work? Great, all right.
Actually, I sent them like 3 versions. So as an organization, you know, and as a program, I need to be concerned with things that other people don't get concerned with. Eligibility requirements. When we were treated as an outpatient clinic versus a supplemental service, there's a weird thing that's occurring. So if you are 26 or under, you're kept on your parents' health insurance, and you can also, because of your disability, get Medicaid. If you have that and it's outpatient, Medicaid will not pay because the clinic is not a participating provider in the commercial insurance. If you go to the commercial insurance, they don't take Medicaid for the copay. So then you have families who are going, I can't afford the $40 copay or whatever the copay is. And they can't get it through Medicaid because that's not a participating Medicaid provider. Panels have been closed for ages in most places. In the city of Philadelphia, it would be impossible to get on a panel because there's so many hospitals within the city that they have filled the panels. So the UPenn program actually got all of our people who were what we call dual eligible commercial and Medicaid because they could bill both. They were the only ones who could bill both. As a supplemental service, we don't have to worry about it because it's not an in-plan service for any commercial insurance. So now we can just see anybody who qualifies for Medicaid. I need to be concerned about, you know, payer mix. Do we have private pay people? Can they afford to pay? I need to be concerned with the amount of services each clinician provides. Is the work distributed evenly? Are they following through on their work? Are they providing the care to people? The types of services and what the balance is on that. We have compliance reporting. We have to ensure to Center for Medicaid that we are doing both preventive, pre-billing and post-billing compliance checks to make sure that people are actually providing the services that we say that they're providing. So you have all of the compliance reporting and monitoring activities. Usually our funders require performance improvement activities and reporting. We have licensing requirements. We're licensed by the state. There can be 3 different licensing bodies in Pennsylvania. And then you have credentialing requirements and monitoring. The credentialing is done by the MCO. Our MCO believes it should be that we exceed all standards because we're special. And then you have what a clinician wants to know. Clinician just wants to know, what does this person need? How can I help them to get better? How can I know that what we're doing is helping the person to get better? So am I writing good treatment goals that I can actually see, is this individual getting better? Think of it as a little mini program evaluation. They have to be able to demonstrate what evidence-based practice they're using, the interventions, all of it. And then what's billable, non-billable, and time frames. So you have all kinds of insanity. I've already talked to you about supplemental services and the value-based payment. And talk about what outcomes determine value. It's usually client experiences that aren't part of the program. They're beyond the program, hospitalization rates, community tenure, criminal justice. Other measures can be just encounter information, type and intensity. Okay, I can tell you how many services they had. Can't tell you if they were good or if it helped them. So which things are we reporting on? And then we have all of our targets. So how do you do it? How do you take this entire thing and say, I just identified about 6 layers. There was more, but you didn't have a long enough time. You have to somehow align that, because I'm down at the provider level. We're nonprofit, but as I say to staff, I need to bring in enough revenue to keep the doors open so that I can continue to serve people. So you have to have both that sort of nonprofit, bleeding heart, I want to make sure everybody gets what they need, but a little business sense, because these additional layers cost money. You know, I say to people now, gee, that training would be really nice. Do you know that it's going to cost $5,000 a year for that one ACT team to go through that training annually? Every time I say that, they go, yeah, we don't need to do that annually. The state only requires a once and done. Good. We'll move to once and done. So you have to actually look at everything and say, do I get the biggest bang for my buck? How do I organize an electronic health record so that it can give me the data that I need? We're a large organization. Every department had their own special form. And they started putting their own special forms into our electronic health record. So this morning, I had a meeting with every case management like group. One individual progress note and one group note. It's only taken about 6 months, and today we all agreed on the one of each thing. So when you're talking about trying to extrapolate data out of an electronic health record, if everybody does something special within their thing, it makes it impossible, because the elements are not the same in each chart. So that's another piece of it, is how do you uncomplicate things that unfortunately lots of people like to complicate. One of the reasons some of our forms are so crazy is because someone comes into Prudential and says, oh, we don't like that, we want you to do this, and we go, oh, okay, and we change it. But we didn't change it for these 20 programs over here. So now we're saying, yeah, if they can't show me a regulation or something in my contract language, I'm going to need to say no, because we need to provide all this other data. So how do I do that? So it's getting an electronic health record and understanding that these are pieces of data that are going in, and how can I get the data in and then the data out? How do I make my data system talk to a researcher's data system? And the other part is literally mapping things. So you may say demographics. Yeah, that's easy. Simple things like demographics. Okay. Gender. Where are we going with gender? It used to be male, female. Now it's male, female. Some systems just say transgender. Some identify it's transgender to male, transgender to female. There's non-gender conforming. I can't even begin to tell you on how many systems there's different things. And not to say that that's not important to do, but it's just a nightmare when you try to make them all line up to find the set that everybody can agree to and collect and put that information together. So literally mapping, what is this data set? And then pushing back and saying, look, you want a global assessment of functioning. We're using this tool and we can give you this. Is there some reason it has to be that tool? And if you're talking program evaluation and it's not the multi-state 38 sites, you have a lot more flexibility to push back and say, can we all come to an agreement? And your goal was a global assessment of functioning. How can we do this in a way that everybody can live with the form that we use to get to that? Again, it's how do we push back? How do we look at things? Peace Program started to use 3 different trauma screens. Because each screen asked one question that the other ones didn't ask. I had to ask, does it change the way that you do the treatment? No. Does it change the way that you would do your analysis? Would it really come out with a difference in the analysis? Well, no. Then why am I doing the 3 for the 1 question? And it's more that sometimes people just don't think. They don't think the process all the way through. So some of you are doing research, some of you will graduate and do research, some of you do contracts, you're working for the city, is to think about, gee, do I move down to the provider level? And before we set something in stone, to actually start to ask the question about what is the burden on the clinician? As an organization, I can provide resources and things, but a clinician can only do so much in a given day. And usually they're the ones who have the burden of collecting this. And what's the burden to the person who's being served? We have a beautiful biopsychosocial that our quality improvement director put together and got all these programs to agree upon. And in order to get all these programs to agree upon it, there's question after question after question. I said, yeah, you got to change that form. She said, why? Everybody agreed upon it. I said, yep, it's so long. Clients are walking out. She said, oh, that's not good. I said, bingo. That's not good. We're not getting the assessment done. There's limited time to do assessment and bill for it. And the person wants to know that you're establishing a relationship and you want to know what their needs are, not that you're filling in questions on the forms. So when we do things like trauma screens, it's like, gee, should we ask if there's an event before we do a screen to see if they have PTSD? Simple questions that people don't ask. But if you start to think about every piece of data that you request is a burden on the person collecting it and the recipient giving the information, it starts to make things not so important. You look and you go, is that really necessary to achieve the goal? So, is all data good? No. More data means more knowledge. Not necessarily. It's a whole lot of data. if it doesn't inform something, then why are we collecting it? Government spends less to get more. So they have you collect data to ensure that there's cost offsets. Pennsylvania, for a supplemental service, I have to show that there's a cost offset. It saves Medicaid money, or at least doesn't cost Medicaid any more money. But in order to do that, they ask for a whole lot of data. So you would think they want to make sure that they use their resources the best. But is that the best way to get to it? And again, as I said, the recipient, they're walking out of an intake that's like, I can't do any more questions with you. That's not a good thing. It's not a good thing. So the goal is to really look at it and look at achieving things by doing multiple things at the same time. I train my staff to say, you're required to do this compliance activity. So we have to call back so many people each week. So Sean went out in the field, he was doing activities in the field. I actually have to call a couple of Sean's clients to make sure that Sean was there. And he did it, because there are unfortunately unscrupulous people in the world who go out and they don't provide a service and they bill for it. We're expected to prevent that. So I call and check to make sure. Now I can call and just say, Sean, I'm calling to verify that Joe came out and saw you yesterday and he spent about 2 hours with you. Is that correct? And he says, yes. No, thanks. And hang up. Well, my supervisors are also supposed to make sure that they are checking to see if our individuals we serve are satisfied with their services. Well, gee, while I have Sean on the phone, why don't I double check? Gee, Sean, know that Joe came out to see you yesterday, right? Yeah, he was out. I said, is he providing what you need? Is it meeting your goals? Is there something else that we can do? He tells me exactly what he thinks of his services. He tells me what he needs. He tells me what his progress is. Guess what? I write it all up. I've met compliance. I've met quality improvement. And since I'm discussing his goals, guess what I get to do? Bill. I just achieved 3 things in one conversation. And I used to have managers pulling their hair out because they did it in 3 separate phone calls. And of course, then people get annoyed. And Sean's like, I already talked to you about this other thing. They don't want to talk about anything else. So if I put it all together, then I get the information that I need. I hit the goals that I need to have. I've gotten the data. I've not put a burden on the participant. And I'm not putting the burden on the manager, the supervisor, the clinician who has to do this. So it's really that constant thinking about, we talk about time management. You don't want to touch a piece of paper twice. So take time management classes and project management classes, and they tell you, like, take care of it, don't go back to it. Like, pick a time, you do things a certain time, touch it once. This is that same kind of thing. I don't want people to keep going back and just having multiple people touching the same thing. Who does it make sense to gather this information? How do I parse it out so that we're collecting what's necessary in the easiest way so it achieves whatever the reporting agency needs from us, or achieves whatever the researcher needs from us? But again, does not burden the participant primarily, and it's a Benny if I don't burden the clinician. But my goal is really the individual served has to give us this information. It's the one thing most people don't think about, is that the individual served has to give us the information. And let me tell you, you're all out. No.
Everything duty read, 7-Eleven,
So
Rite
a
Aid.
$5 7-Eleven gift card does not compensate an individual for giving you all this research data. And most of your IRBs don't let you give much, and the person's on disability, so they can't get much. And people honestly think when they set up their research that that's a good thing. That's, well, we're gonna give them a $5 gift card. No. That's not what they want. They want to know that when they come to see Marie for therapy, that Marie cares about what's going on in their life and wants to help them get better, and they want to work on this problem relationship that they have, or they want to learn to deal with the stress so that they can keep their symptoms down. They don't care if you want to give them a $5 gift card to answer 32 questions. They don't care about that. They want me to care about them getting better. So we tend to look at things in this is my theoretical model, this is my hypothesis, these are my questions, how am I going to get that data? And we go from that top down versus maybe needing to think about, I want to achieve this, and instead of up here, thinking about the person down here. And how can I get that? So instead of, that all funneling and sort of the pressure goes all on the people at the bottom, is to really have that be a discussion between the top and the bottom. You're going to get the data that you need. And you're going to get better data. Because if I'm frustrated, if it's too hard to do, you have missing data. Or you have bad data. It's like, I just don't want to answer the question, so I give you whatever answer is the first thing in my head, and I'm not going to think about it for 2 seconds. So you get cleaner data, you get what you need, the burden is less. But the simplest way to do that is really to map it out. And do they do logic models anymore? Logic models are sort of nice because it lets you go along and start to see, okay, this is what I need. Add in the column, what does the provider already get? And then try to match that. If they're already getting X, Y, and Z, you don't have to have it be X to whatever, Just, if that gets you what you need, get that, do that. But follow your logic model, have your column of data that you need, and the column of what does the provider get that matches the data that I need. And you're really going to end up having a much better evaluation. People are way happier to see you and deal with you. And again, there's less burden, there's less cost on providers who, at this point, are beyond underfunded. We're lucky, we're a specialty organization. We deal with people with serious mental illness. So unless they make Medicaid go away, which we're threatened to do, we'll make block grants go away, which we're threatened to do, we're still in pretty good shape because of the population that we serve. Other organizations who are involved in research as well, who are much more broad in who they serve, those organizations right now are in very precarious positions and very anxious. So in doing a study, they may feel more pressure to not do it because they don't know where their funding is. They don't know if they're going to serve people. I was in DC a couple of weeks ago for the CIMH 10% study, and the question was, so we're collecting all of this. Do we know if the block grant's going to have this money in it for next year? And they said, well, the only thing that we can do is act as if. So we're all going forward, acting as if. And of course, those of us on the provider level are like, yeah, I'm going to collect a whole lot of data. If they wipe this out, I'm not going to be happy. But, you just have to sort of be flexible and go with the flow. We'll collect the data, but we don't know what the changing landscape is. And that changing landscape for the provider creates a changing landscape for you as a contractor or a researcher. Because depending upon where they're at, they have resources or don't have resources in order to participate. So that's the end of my talking. And
questions for Dr. Krantz?
Hi, I'm Janice from DOHMH. I'm really wishing I had met you a year ago when we got started on one of our initiatives. So it's with the whole Thrive NYC mental health deal, and we're primarily working with children 0 to 5 and their families and providing mental treatment consultation and all this jazz. So I'm the data analyst for this particular one, and we were laughing because there were so many things before I got on board that they wanted to collect from all these 7 clinics. Take in mind, we have 7 clinics throughout the entire city, and they each have their own EHR and trying to figure out who's going to pull up. And some of them do have great IT staff, and some of them, the IT staff is the person who actually just enters the data, which is really no IT at all. But like the mapping thing, I remember the gender example was a great one because DOHMH kind of breaks down gender in like 10 different categories. So, you know, male, female, transgender to X, Y, and Z. So I remember sending this out to the providers, this Excel sheet with probably 5 Excel document with 5 different sheets with all this stuff. And I was like, so this is what we need from you. Yeah, I didn't want to answer my inbox for the next 2 months because the responses I got was just like, so who actually told you? They were like, you're lucky that we even put other in the category, and that was it. And I mean, that was what we had to grapple with, and I think we finally just had to come to the point where we literally switched it and we said, this is what we would like. What do you have? What do you not have? And to really, I think the list started at 72 different demographics, and I think we got down to about 15. But exactly to your point, did it answer the question that we needed to answer? Yes. And even more so, we were thinking about the assessments that we even ask our providers to do, and it's just like, man, you know, why haven't we reflected the question, like, how long does this actually take? Like, we've read the papers that say this tool takes about 10 minutes to, you know, administer, but how much time does it actually take? So we can see, do we really need to assess this? Or again, what is our what do we want to see? So, I mean, this was just great. We were over here talking, we have to find a way to get her in so she can come. But no, I want to thank you for this, because this is even helpful for us going back and really talking to like our supervisors and saying like, the burden may be a lot, like especially now we're finding that this is a need and having to do this for so many people. Yeah, so.
Some things, you know, if you think about the time that they put on, you know, when I was doing intake assessments as a direct care worker and did them all the time, I could do a biopsychosocial very quickly. Yeah. I'm an administration, guys. You know, you sit me down, I can still do it, and I know the diagnostics, I have to approve all of these things, but it's going to take me longer. I have to, people laughed at me this morning. I was in this meeting, and I'm trying to pull up, or one of those web share things, trying to pull up a document. And one of the other directors says, we have to create the service and the electronic health record for what they want to see. And I'm like, okay, do this, and then you do it. And she said, get out of my way. She jumped in and did it in like seconds. I would have been there for about 5 minutes. So some of it is also, even it might be correct that it only takes 10 minutes to do it, but if you don't do a lot of them, it could take you much longer. So again, thinking about things of, if you, you know, something that you're asking people to do with, you know, 1,000 people repetitively, people are going to get quick, to do it quickly, versus they've got 5 people and they're going to do it every 6 months. It's always going to be slower.
No questions, thoughts? On behalf of CUNY and if I may say the city as well, and everyone else who's new, I want to thank you for a really terrific presentation. That was both research and scientific, but also tremendously pragmatic. So thank you.